All right, guys, how's it going? So the lecture, excuse me, the lecture that I recorded, for some reason did not record. So I'm doing it again. So here is, let me share my screen and we'll get through this, and I'm going to post this online for both of you, for both sections. So here we go. So tonight we talked about the urinary system in class, right? And so obviously, if we look at the anatomy of the urinary system, we're going to see that it includes not only the kidneys, right, but the ureter, the urinary bladder, and then the urethra. So those are those key structures of the urinary system. We can see that above the kidney, we have the adrenal gland, obviously the blood supply to the kidneys, the renal artery and vein, and so on and so forth, right? Now, the main function of the urinary system, obviously, is to work on waste removal, water balance, so salt balance, sodium potassium balance, and so ultimately the end product of the function of the urinary system is urine, right? So urine is a blood filtrate. We'll get into that physiology here in a second. The urinary system is also responsible for control of pH and obviously control of blood pressure through the renin-angiotensin system. So the functional unit of the urinary system is the glomerulus. Okay, so the glomerulus is essentially a coiled tube that connects to basically a renal arteriole, and the renal arteriole essentially pushes blood into the glomerulus, where it is essentially filtered, right? And out of that is filtered, obviously, sodium, potassium, and various other ions. The end result of blood being filtered through the glomerulus, through the ascending and descending tubules, is production of urine. Okay, so that is really the main function of the nephron itself, right? So that nephron obviously being made up of the glomerulus and that glomerular artery there. So the kidneys ultimately filter about 48 gallons of fluid a day, right? And end up making approximately 1 to 1.5 liters of urine every 24 hours. Clearly, over 99% of that urine gets reabsorbed. Okay, but this is the functional unit of the kidney. Oftentimes we see in pathology such as acute kidney injury, those are often sequela or diagnoses or problems that result after from another diagnosis. An example that we often see in the athletic training world is heat stroke, right? Often, giving rise to multi-organ failure, obviously being the kidney, the kidneys being one of those due to acute kidney injury. So when the nephrons are damaged, that can obviously impact overall kidney function. So what about some combining forms, right? So we have kidney, and the combining forms there are nephro and reno, urine being urino or urea, right? The ureters, which are the tubes that lead from the kidneys to the bladder, right? So the combining form there is uretero, okay? Urinary bladder being cysto or vesico, okay? Urethra being urethro, and then glomerulus being glomerulo. So the renal pelvis is actually a structure at the base of the kidneys, and that is actually, it can be the site of infection for a condition called pyelonephritis, okay, which is essentially inflammation of the renal pelvis. So this is actually often a consequence of bladder infection. In my clinical practice as an athletic trainer years ago, we saw a young lady that came in that I was taking care of, and this young lady had multiple urinary tract infections, probably 20 to 30 throughout her life. Well, one day she came in to see me. She had a fever of 104 and was complaining of significant flank pain. So, obviously, on clinical exam, you can actually palpate the kidney, and the way that you do that, obviously, is you place one hand under the lower back, bring your top hand down over the costal margin, lift up with your bottom hand, and down with your top hand, and right in the middle you'll find the kidney, right? but she was very tender, obviously over the kidney, and we sent her in for antibiotics, and she ultimately improved. Okay, all right, let's talk about some more terms. So cystitis obviously is a bladder infection. Okay, this can obviously a result of this can be urinary frequency or the need to urinate often. Right, we talked about pyelonephritis already, and how this is a result of urinary tract infection. Right, so obviously cystitis or ureteritis can actually result from urinary tract infection, which then can obviously spread to pyelonephritis if not treated appropriately. So glomerulonephritis, obviously, as we already talked about, can be present, maybe not just with infection, but also with acute kidney injury and other pathologies, as we talked about. Okay, hematuria. Okay, this is blood in the urine. We see this often after trauma. Here in a minute, we'll talk about kidney stones and actually how hematuria is actually a consequence of common medical procedures called lithotripsy used to treat kidney stones. So nocturia obviously is a term for urination at night or excessive urination at night. Enuresis is essentially wetting your pants or involuntary discharge of urine. Incontinence is the ability to control your urine or your stool. And these are different forms. There's urgent continence and other types that sometimes are caused by pelvic floor dysfunction. So nocturnal enuresis, wetting the bed, those types of things. Polyurea, which is a small amount of urine or scant urine, versus polyurea. We often see polyurea a lot of times in people who are diabetic. Obviously, we talked about this in class earlier today. Ultimately on a lab test, particularly on a urinalysis, we should typically never see glucose in the urine, right? Glucose in the urine is actually always abnormal, right? There are certain times, though, however, with people that are diabetic, when their blood glucose reaches over 180, that exceeds what's called the renal glucose threshold, and they will then spill glucose into the urine. And we often see that then they will obviously have glucose in the urine that will show up on the urinalysis, either with a urine dip or with a formal urinalysis done in the lab. Whoop. Okay, terms. So nephrectomy. Okay, this is nephro, so kidney, right, and then ectomy, surgical removal of a kidney. One thing that we mentioned in class today, right, is the presence of the solitary kidney. Right, and my cheesy joke from today is it's not a kidney that doesn't have any friends, right? It's the presence of just one kidney. So all of us, maybe one of us in class, or maybe someone that we know was born with or actually has only one kidney. Okay, now clearly, and a question that I asked in class today was, would it be indicated, yes or no, for someone with one kidney to play a contact sport? And the obvious answer to that is no. Right, because in the event that they suffer trauma to the kidney, they're obviously risk having to undergo removal, and would potentially necessitate a transplant, depending on the extent of the damage to the kidney. Another term that we often see, particularly when dealing with kidney pathology, and these are my personal nemesis, are kidney stones. I have actually dealt with these myself, and they are zero fun whatsoever, right? So there's two terms that we typically utilize when talking about kidney stones. One of those is nephrolithiasis. The other is a renal calculus. Okay, that is the singular term for a kidney stone. Renal calculi is the plural. So usually, depending on the size of the kidney stone, anything that's 4 millimeters or smaller can typically be passed through the urethra, right? So generally speaking, you can pee it out. But if that stone is larger than 4 millimeters, it will have to be addressed surgically, either be a lithotripsy, which is essentially using sound waves to break up the stone, or via removal of the kidney stone surgically. A couple of Septembers ago, I had surgery to remove a probably 9.5 millimeter kidney stone from the base of my left kidney. That was just so much fun. So they went in and they broke that kidney stone up, and definitely not uncommon. And you'll get this question from patients after you have this done. The first time that you go to the bathroom after this type of a surgery, you will pee blood. Definitely that's definitely going to happen. You will pee blood, right? So now the other thing that they didn't tell me though is the next morning I was feeling really good and putting on my obviously got dressed to go to work, was walking down the back steps to go to the car, and my pain medication wore off. What they didn't tell me is that the 9.5 millimeter stone that I had had broken up into about 30 pieces, right? And so at that point, I was in really, really, large amounts of pain, and spent the entire day either on the toilet or on the couch, and spent the entire day passing those stones. All right, so let's talk about this for a second. What exactly is a kidney stone made up of? So the number one, kidney stones, generally speaking, most of the time, are made up of a compound called calcium oxalate. Okay, so unfortunately for me, calcium oxalate is something that is essentially a component of many of the foods that I like to eat. Spinach, I like spinach. Chocolate, right? Many different types of things that have calcium oxalate inside of them, right? Or that are compounds in some of these foods. And so I, as a person, am categorized as a stone former. So I have to essentially eat less of these foods that have high amounts of calcium oxalate. One thing that's often recommended for stone prevention is the use of citrate, high levels of citrate in the diet, which can be done by obviously eating, citrus fruits and or drinking like water with lemon in it, or other things as well. Okay, so here's a picture of a kidney stone on a KUB X-ray. So KUB stands for kidney urethral bladder X-ray. Kidney ureter bladder X-ray, sorry. So you can see the stone here sitting in the upper left quadrant of this individual's abdomen. Okay, so here's the KUB. Here's another stone here on the right. You can see it. So how do they typically utilize these diagnostically? So these KUBs are done beforehand to get an idea of the size of the stone, but then also these are also done a few weeks after surgery to indeed confirm that those stones have in fact been broken up and that they are no longer there, right? So to determine the extent of success of that surgery. Okay, we're going to shift gears and talk about the female reproductive system. Okay, so obviously this consists of the uterus, the fallopian tubes, ovaries, cervix, and the vaginal opening. Okay. So when we talk about the uterus, obviously we got three layers here. So the perimetrium, the outermost covering, the myometrium, which is smooth muscle, right, and the endometrium, which obviously builds up and then is sloughed off over the course of a 28-day menstrual cycle that's experienced by women every month. Also fallopian tubes, right? These are also called oviducts, and obviously as an egg is released from the ovary, this travels into the fallopian tube, often during sexual activity and then subsequent conception. This is where the egg is often fertilized by sperm, and then it makes its way into the uterus and implants itself on the uterine wall, resulting in an embryo and then eventually a fetus. Okay, let's talk about some combining forms here. So for ovary, right, we have the term ophoro, okay, ovary, or ovario. Excuse me, you'll see those used interchangeably generally. Okay, salpingo, combining form for oviduct, but in the world of ear, nose, and throat also refers to eustachian tubes. So also refers to your eustachian tubes. Okay, so if someone is doing a salpingoscopy, they are looking inside of your fallopian tube with a scope. Okay, uterus. So when we talk about obviously hysterectomy, it's the removal of the uterus. We'll talk about some different types of those in a minute. So gyneco, okay, is the root word for woman. Okay, a gynecologist is a specialist in women's health. So then we have the amniotic sac. So this is a sac that develops during pregnancy and contains the amniotic fluid. So this is obviously, there are times where an amniocentesis is performed during pregnancy, not only to ensure that the baby is healthy, but that also that the mother is also healthy as well. And then there's obviously also the cervix, right? We'll talk about when we get into the musculoskeletal unit as well next week. This is also a combining form for neck, right? So cervico can mean either the cervix being the opening to the opening to the cervix and the cervix, or the neck, right? So we'll see those terms used interchangeably. Cervico can mean either or. Okay, so in the event that a woman needs or decides to undergo a hysterectomy, there are different types. So generally speaking, total hysterectomy would include complete removal of the uterus, and that is resected and then removed through the vaginal opening. Then there is also a radical hysterectomy. Now, the difference being that with a radical hysterectomy, the uterus is removed, and the woman typically also undergoes a salpingo-oophorectomy, which is a removal of the ovaries and the fallopian tubes as well. So that is the main difference between those two procedures. So we posed a question in class earlier that there are typically two incisions, as you can see below at the bottom right here, right? And so we have a vertical incision and then a low transverse incision. And I asked the question in class, why do you think a vertical incision could be problematic for a woman? Okay, and so we posed the question, and we had I thought it was a really good, productive discussion. But let's talk about that. Okay, so we have obviously the rectus abdominis here. I'm going to do some badly drawn pictures here. So we have the rectus here. Rectus abdominis is the outermost muscle. I'm going to draw my little rectus. This is a guy that's in shape. He's got his muscles here. Fun times. Guy's in shape. Okay. He's got his internal obliques here, his external obliques here. Okay. This is what my rectus looks like this. It just looks, it's a whole different ballgame, right? But why this question matters, so that at the most internal layer of the abdominal muscles, the most internal of these muscles is called the transverse abdominis, okay? And the fibers of the transverse abdominis run in a horizontal fashion, just like so. Okay, they run horizontally. Now, here's the issue. You can imagine that with a vertical incision, as that gets carried down into the uterus, we actually end up cutting the transverse abdominis right in two. Why is that a problem? That's a problem because anytime that we have a patient and we're wanting them to work on core stabilization, right, potentially for low back pain, or to help them retrain the pelvic floor, right, that transverse abdominis is required to contract horizontally, just like this, to contract and then relax, right? Excuse me, to provide obviously stability to the lumbar spine and the core in general, but also to help with activation of the pelvic floor. All that being said, I am an advocate for women who choose to have children and who have to either undergo a normal vaginal birth or who have to undergo a C-section for having pelvic floor therapy after they have a child, right? Because it's extremely important, not just for the muscular activation after that type of a life change, but it's also obviously important for the quality of life for a woman after that as well. Okay. All right. So more pregnancy terms. Okay. Gravida or gravid is something that obviously means pregnancy. Okay. This can be used as a suffix or as its own word. So we use the word gravida to mean number of pregnancies. So if a woman is gravida 2, she has been pregnant twice, right? Para means a child carried to term. So if a woman is gravida 2, para 1, she's been pregnant twice, right? And has had one child that she's carried to term. Okay. So obviously if she is gravida 3, para 2, then pregnant 3 times, carried 2 children to term. All right. So the average pregnancy is 40 weeks gestation. Full term is considered 38 weeks. I just had a nephew born at, I think, 36 weeks. Luckily, he did fine. But then the poor guy got COVID in like his 2nd month of life. But he's doing great. He got better. So that's kind of a rough way to start to come into the world, but he's fine, thank God. So, all right, okay, terms, more terms. An ectopic pregnancy. All right, this is when a zygote, meaning a sperm and an egg, do not implant on the uterus. They actually implant in a fallopian tube. This is extremely painful. I've actually had a patient that's presented with this. She came in and was having a lot of abdominal pain, and after a careful history, and discussion, we decided to send her on for referral to an OBGYN. But this was a very difficult situation. And it was also very painful for her. So an episiotomy, right? An episiotomy is when an incision is made at the base of the vaginal opening, generally to allow the infant's head to pass through during pregnancy. Often for women that are giving birth via a vaginal birth, there are times where it can be very difficult for the head to pass through the opening. As I'm sure you're all aware, not to be too graphic, but there can be tearing of the vaginal opening, particularly as the baby's head attempts to pass through. And so sometimes there will need to be an incision made to help the baby pass through with hopefully minimal trauma to the mother. Right. So involution, this does happen. This is actually abnormal shrinking of the uterus after birth, and also some spasm can happen there as well. Right. So menses, really no explanation there. This is the monthly cycle experienced by women. On a normal cycle, obviously cycles can also be very abnormal, but in a normal average case, this would last for approximately 28 days. And this is where the inner lining of the uterus obviously builds up and then is sloughed off when menstruation begins. So endometriosis is essentially where the inner lining of the uterus builds up to such a degree where abnormal bleeding and pain can occur during the monthly cycle. And this can be obviously very painful and very debilitating for women who do experience this. Okay, epidural injections. Okay. So this obviously is a procedure that's often used for obviously pain control to allow a woman to give birth, hopefully with minimal pain or discomfort. So, I posed the question in class, what would be the issue if the physician or the person performing this procedure maybe, because you can see here how the needle in this picture is actually positioned to inject medication directly onto the spinal cord. But what if the physician or the operator, the person doing the procedure, actually went a little bit too far, excuse me, went a little bit too far lateral and inadvertently injected the medication onto a nerve root and not into the spinal cord? But we decided, in answering that question, that this person would only obviously experience pain relief, right, along the course of the nerve root innervated by the skin at that level. So let's say it was L2, right, the second lumbar nerve, right? That person would only really have pain relief noted essentially throughout the hip, that basically the hip and the mid-thigh on one side. But with the needle correctly positioned and medication administered in the middle at the level of the spinal cord, everything obviously below that level on both sides goes numb. Okay, all right. Shifting gears to the male reproductive system here. Okay, so obviously we have clearly the urinary system here being the bladder, and that urine obviously passing, through the prostate into the penis, being expelled into the environment. But what about the reproductive system in men? So we have the testicle here, right, which is where sperm is produced. Okay. And then obviously with the epididymis is actually a storage, kind of like a reservoir actually for sperm and semen. That's where that is stored. You can see it right here on the back of the testicle. And that actually opens up into a long duct called the Vas Deferens. So the Vas Deferens is essentially a tube that runs from the back of the epididymis all the way up to the prostate gland and Cowper's gland. And this is actually where further properties of semen, like sugar and other, water and other things are kind of secreted along with the semen. And this actually is where semen receives kind of its final makeup, right? And so obviously during sexual activity, the corpora cavernosa here on either side fill with blood. as you know, the penis becomes erect, and then obviously the male ejaculates at the end. So getting into a little bit more information on that, and we'll talk about kind of male fertility here in a second. Okay, so combining forms here, obviously for testicle, are testo, orcho, orchio, or orchido. Okay, there are many different terms that we use to refer to testicles. But okay, so obviously testes is plural, testis is singular. So cryptorchidism, okay, and I'll draw a picture and explain this. This is actually a really fascinating diagnosis, a really fascinating kind of clinical problem. So little did you, I don't know if you knew, but as guys, when we develop, right, our testicles are actually located behind our kidneys. Crazy times. So I'm going to draw you some pictures here. All right. So here's my poorly drawn kidney. It's like, oh, that's a really bad. I'm going to clear. That's a bad kidney. Like even worse than my normal. All right. Here's another kidney. We're going to try this again. Okay. A little bean. Oh, that's so bad. Okay. Here's a testicle. Okay. There's my epididymis back there. There's my vas deferens and everything. Now, here's the deal. As a baby, my testicles live behind my kidneys. We don't. So really, someone asked me earlier why that is. Embryologically, I mean, the only answer that I have, and we really don't know, but that's embryologically how we develop. And we think that it's due to the increased temperature in the abdominal cavity that allows for obviously mitosis to occur and obviously continued development of that tissue. Obviously, though, once we are born as toddlers, okay, and here's the scrotum down here. Okay, so as toddlers and as newborns, eventually what happens is that testicle will fall into the scrotum. It'll drop. Okay, the testicle drops into the scrotum. Normally, that's what happens in newborns. However, in cryptorchidism or someone with an undescended testicle, that doesn't happen. Okay, the testicle may get kind of stuck in the inguinal canal and or never drop at all. So generally speaking, when the child is small or a toddler, they will actually go in and they will actually pull the testicle down into the scrotum, and then they will actually sew basically the fascia around the testicle to the base of the scrotum, so that the testicle does not reascend into the inguinal canal. And that procedure is called an orchiopexy. Okay, an orchiopexy. So obviously, then also as well, we can see that an individual may be born with the absence of testicle. Okay, that's called anorchism. Okay, so vaso, that's referring to the vas deferens. And then obviously vasectomy. This is when a male will have both ends of the vas deferens cut and tied, right, so that semen cannot pass through from the epididymis into the urethra for ejaculation. So obviously, andro is a root form, meaning masculine or male. The androgens are the male hormones like testosterone. Okay, and so let me clear that. And here's a picture of a vasectomy. So you can see obviously the cut being made, and the vas deferens being tied off at the top and the bottom. Okay. All right. Let's talk about a little bit more terms here. Whoops. A few more terms. So BPH, okay, benign prostatic hypertrophy, also referred to as benign prostatic hyperplasia. So BPH, okay. First of all, the term benign, okay, I asked you guys in class earlier today, what do you think the term benign means? Okay, benign means, okay, it has a few different definitions. Not metastatic, not cancer, okay. Also considered to be something that, while abnormal, will not affect your physiology substantially, your normal physiology substantially. Okay. So with benign prostatic hypertrophy or yeah, with BPH, tends to affect men between the ages of 50 and 60. We've actually noticed it earlier, and now we're doing more routine screening, obviously, in men that are actually now in our 40s. Okay, so let me draw you guys a picture. We're going to talk a little bit more about BPH. This is something that we touched on in class, obviously, but I'm going to share a little picture with you. We're going to talk a little bit more about BPH. So as one of my mentors always said, okay, certain pathologies that we know about live in a range, not a place. Okay, so here, okay, I'm going to draw this here. So here is here's my prostate. Okay, it's pretty enlarged. Okay, however, all right, this is non-obstructive. Okay, while the prostate itself is enlarged, it doesn't affect urine flow. However, over here, okay, we have an obstructive BPH because we can now see that the prostate is actually enlarged to such an extent that it is actually inhibiting or preventing entirely the flow of urine. Okay, that is why screening is so incredibly important for men. And there are obviously situations in which, with this type of a problem, particularly with obstructive BPH, obviously prostatectomy may actually be indicated. Clear my little whiteboard here. Oh no, sorry guys. Let me share again. All right. There we go. Okay, so obviously in situations where that BPH is obstructive, we may require transurethral prostatic or prostatic resection. Now, here's the deal. Somebody asked in class earlier today, in the second section, they asked, so, Wade, what's the difference between a transurethral prostatic resection, right, and just a regular prostatic resection? Here's the difference. When you see the term transurethral, okay, that is actually the approach that they took. So they actually made an incision through the urethra, likely between the scrotum and the penis, to get into the pelvic cavity to be able to do the prostatic resection. Okay, obviously, as we know, resection, as we see that root there, ECT, which means they are obviously removing, right, or cutting out. Okay, so prostate cancer obviously is the most common male cancer, as we know. So obviously, very, very important to get screened for men. Okay, normal sperm count. We said we were going to talk a little bit more about male fertility, so let's do that. Obviously, with every ejaculation, a male, generally speaking, within the semen, there typically are going to be between 60 and 300 million sperm per ejaculation, and that is considered normal. Obviously, between 20 and 60 is considered oligospermia, and then obviously anything under 20 million sperm per sample of semen is considered sterility. So just some general information there regarding male sterility as well. So here's an example of BPH. Obviously, you can see the prostate here. Obviously, Cowper's gland is contained here as well. You can see, though, okay, that as the prostate begins to enlarge, if it were to enlarge to such an extent that it actually begins to place pressure on the urethra itself, that there could actually be a big problem with urination. So you can see how, if this got big enough, it could obviously obstruct urine flow. Okay, so that's the lecture for today. Once again, guys, my apologies for the first section this morning for class, for missing that Zoom link. And then I tried to record the lecture this afternoon, but my phone went. It was kind of crazy, so it didn't record what it was supposed to. But this is it. So got this recorded for you guys. It was great to have you guys in class today. It was fun. It was super fun. So I hope that you guys are having a great day, that your Tuesday was great, and I will see you guys on Thursday. Okay, thanks, guys.